First of all, I would like to thank Shlomi and Dragu for inviting me tonight. This lovely meeting. Ladies and gentlemen, the discussion is hypothermia and adjunctive pharmacological therapy in acute coronary syndrome. The hypothermia can have some physiological effects requiring some problem in coagulation. Like below 35 degrees centigrade, we can see some platelet dysfunction and mild thrombocytopenia. But below 33 degrees centigrade, it may appear some problem in the synthesis and kinetics of coagulation factors. From the point of view of coronary perfusion, we know that hypothermia may cause some coronary vasodilation, but it's true in patients without atherosclerotic disease. And those with atherosclerotic disease and stenotic lesion may cause vasoconstriction below 35 degrees centigrade. Of course, hypothermia will cause some cardiac metabolic rate changes. Mainly, we will see bradycardia, and we'll see also enlargement of the PR segment, the QT, and the widening of the QRS. There are some studies depicting also reduced impulse conduction speed. Another interesting change during hypothermia is electrolytes serum levels. We know that under hypothermia we will see some hypomagnesemia, hypovolemia, and hypophosphatemia, and this is due to changes due to intracellular shift and tubular damage causing excessive renal excretion of these electrolytes. Also, under hypothermia we'll have some insulin changes from the point of view of physiological, because we have an increased resistance to insulin and also a decreased secretion of pancreatic secretion. But let's have a look at what's going on with the platelets during hypothermia. But first of all, I would like to remind us that our study discussion are not healthy people. We're speaking about patient having a cardiac arrest. And during cardiac arrest, there are some changes which this ischemia perfusion phenomenon will bring to the platelets. For example, what's going with the intracellular calcium. Due to the changes in NAKATPase dysfunction and also due to mitochondrial dysfunction, there is an increase in intracellular calcium into the platelets. Also, there is an increase in vasoactive substances such as thromboxane A2, bringing an activation of the platelets. But it's more important maybe to speak about what's going on with the main activator of the platelets, the ADP, which, as you know, it's working through two receptors, the P2Y1 and the P2Y12. When taking platelets from healthy donors and combining them with a different concentration of ADP, always the percentage of aggregation of these platelets will be higher during hypothermia than normothermia. A number of studies demonstrated. Other studies demonstrated that at different concentration of ADP, there are similar percentages of aggregation during normothermia and hypothermia. But even more interesting is that when you add to these platelets and to ADP also Plavix clopidogrel, you will see that at low temperature still those will have higher aggregation than at normal temperature. Okay, so we'll say maybe it's working to the other receptor, the P2Y1. So they took the same platelets, they put it together with the ADP and with the P2Y1 blocker, and still the same effect, higher aggregation at low temperatures. And even more interesting, it's that the same effect, it can be observed if you add both blockers. Okay, but this, what you saw earlier, it was with platelets coming from healthy donors. What about platelets coming from STEMI patients who are having primary PCI? Those patients already have some activated platelets. The same results. Here are the results coming from this patient who had aspirin, 300 milligrams of clopidogrel, and as you see, the degree of aggregation was higher at 33 degrees centigrade than at 37. This study is more representative for what our discussion. Patients coming with cardiac arrest and treated with hypothermia, receiving aspirin, clopidogrel, and those with red dots having hypothermia and those with white dots having normothermia. As you can see, when this aggregation was measured by verified now percentage of inhibition, those with hypothermia had almost none of platelet inhibition during the first 24 hours and a little bit of inhibition after 2 days, as compared with those with normothermia. Similar study, but aggregation was measured by PRI percentage, which has to be below 0.5 or 50% for satisfactory aggregation inhibition. Here you can see patient receiving aspirin, 300 or 600 milligrams of clopidogrel, and after 1 day, none of them had a good inhibition of aggregation. Just a small part of the study population, after 3 days, had some inhibition. This is a study published this year in Resuscitation comparing 80 patients with normothermia and 84 patients with hypothermia arriving due to ACS and cardiac arrest. As you can see also here, there is a big difference in the aggregation during normothermia on the left side and the hypothermia on the right side, with patients having hypothermia with a low level of inhibition of platelet aggregation. But if you are looking according to the antiplatelet agent used, you can see that those with clopidogrel have low inhibition during hypothermia. Those with ticagrelor, a smaller difference but still significant. The only drug which caused no difference between normothermia and hypothermia was prasugrel. What about 2B3 agents? There's another study with patients coming with cardiac arrest and treated with hypothermia, aspirin, clopidogrel, 2B3A, and everybody receiving hypothermia. As you can see, those with red dots received 2B3 agent, while those with white dots did not. During measurement of 2B3A activity, only those receiving 2B3A under hypothermia had a better inhibition of the platelets. This is another small study coming in 2003 and showing that platelets from healthy donors combined with different types of 2B3 agent at 32 or 37 degrees centigrade, only reoperoximab worked well under hypothermia. However, if we conclude this fact, we can say that it seems that hypothermia is acting differently on different classes of antiplatelet agents. Most probably it's having no effect on aspirin. Clopidogrel, most probably it's not the agent of choice for patients which are treated with hypothermia, and probably we should add a 2B3A agent to those patients also together with the novel antiplatelet agent. The second point I would like to address together with you is the potassium level in hypothermia. As we saw earlier, hypothermia can cause intracellular shift in tubular dysfunction, causing some hypokalemia, but it's very important to look also to reworming, which can cause desequestration from intracellular space, and finally hyperkalemia. So the key point here is a good repletion of kalium during hypothermia and maintaining the serum levels above 3 millimoles per liter. Only the other recommendation is to use a slow rewarming to keep this desequestration at low levels. This is a study coming from our hospital in Rambam, where all patients were having potassium levels above 3 millimoles, and we looked at what happened with the QTC. All patients having mild therapeutic hypothermia have a prolonged QTc after 12 hours, and it was significantly longer than those treated without hypothermia. But the most important findings in our study is that recurrent ventricular arrhythmias during first 72 hours was a lot lesser in patients treated by hypothermia than those by conventional treatment. And it was correct also for patients arriving for no MI, MI, or patients with EF below 40%. The last point, what's going on, the glucose level in hypothermia. We still have an unclear target blood glucose levels in CCU, according to the trials published earlier, Nice Sugar and others. But hypothermia is causing an increase in blood glucose levels due to reduced utilization, decrease in pancreatic secretion, and increased insulin resistance. However, a number of studies describe the fact that elevated blood glucose levels and increased blood glucose variability, that the difference between the minimal and the maximal levels of glucose during hospitalization, are surrogate markers for bad outcome, mortality, and neurological for our patients.